Government and Industry Affairs for Siemens Healthcare. And now I'll turn it over to Charlene to begin.
Thank you, Linda. And thank you so much for joining us today. As Linda mentioned, I'm Charlene Underwood, responsible for the Office of Government and Industry Affairs at Siemens. The GPS that you see depicted is truly a sign of the times. You're going to need some smart tools to help you navigate through what promises to be a circuitous route to healthcare reform. So to that end, I'm very pleased to welcome our guests today from NextGen and from the Center of Health Transformation, who will provide you with some education about what the future may hold. Let me walk through the content of what we're going to cover today. As we have in each of our ARRA webcasts, I will provide you with a short update of ARRA-related activities. Charlie Jarvis, who is Vice President of NextGen, will then cover information related to the ambulatory market and medical home initiative. David Merritt, Vice President and Director of National Health Policy for the Center of Health Transformation, will provide an overview of healthcare reform provisions. And former Speaker Newt Gingrich will outline his views on these highlights and give us a view on what the future portends. So let me move on to the update on ARRA High Tech. You will see the timeline on this slide of the rollout, and here you will see depicted 3 rules that will enable meaningful use. The Notice of Proposed Rulemaking on the definition of meaningful use, the Interim Final Rule on standards and certification associated with the achievement of meaningful use, and the Certification Process Rule itself, which was released in March. All public comment for these rules is now closed. There's been a substantial amount of public comment submitted to these rules, and currently the Office of the National Coordinator and CMS are reconciling the thousands of these comments that they've received. We're anticipating final and or interim final rules in late spring, the last day of spring being on June 20th. So we wanted to take a moment and get your view in terms of what might be helpful for you in preparing for the final rule. So to this end, we're going to ask you to respond now to an interactive question because we at Siemens, as others in the community, are preparing information and products based on the information we have available. So what we'd like to know is what would be of value to you as you prepare to, if you will, recalculate too. So it'll take a minute to respond here. So I will read the question, and then they'll respond. Okay, here we go.
And then they can hit the submit. Once you make your choice for each of the questions, then hit submit.
Okay, so the question is, and I think you see this on your screen, when the final meaningful use regulations are published, what is the most important information you will want immediately to have communicated with you? Pick from the following. First area is changes to the proposed from the proposed to the final rule, and you'll see a list of choices there. And the second area is product plan updates. And can they pick as many as they want?
Yes.
You can pick as many as you want. But we ask you actually to use a little discretion so you can give us some guidance, if you will, please.
And again, when you're finished, hit the submit button.
Okay? All right. Okay. So today our webcast is on healthcare reform. And this next slide shows you 2 arrows, actually, that connect in some way ARRA High Tech and healthcare reform. And there's a lot of confusion about those 2 topics. As you will learn, ARRA and healthcare reform are 2 separate pieces of legislation, although they have some dependencies. ARRA is focused on increasing adoption of HIT across our nation. Healthcare assumes ARRA was successful and builds on a solid HIT infrastructure to strive to make improvements to the quality and efficiency and reduce the cost of health care through a variety of different mechanisms. So again, they're supportive but different. In preparing for this webcast, we chose to invite NextGen to co-sponsor with us because they too are members of the Center for Health Transformation. And we are pleased to announce that Siemens and NextGen has just renewed a 7-year agreement to continue our partnership. With NextGen Healthcare, we have the best of ambulatory and the best of acute working together to achieve a shared development goal, a world-class interoperable electronic health record. On this slide, you will see goals and initiatives depicted that we are working together on. In the emerging, more patient-centric world, you will see Wendy, our patient, whose health will be better managed because of our work on these initiatives together. Let me turn the presentation now over to Charlie Jarvis, who will tell you more about Wendy, how she will be cared for in the medical home environment, and why that's important to healthcare reform.
Thank you very much, Charlene, and welcome, everybody. Hopefully you're seeing Wendy right now, and I want to talk a little bit about how she fits into the big picture of the medical home. The medical home environment is something you're going to hear more and more about as we move forward in healthcare reform. The concept is one of an all-inclusive patient care delivery system managed by a primary care physician who is managing the information as opposed to the finances of a picture like this. Now, using the EPM and EMR, a physician can gain access and communication, patient tracking, all-important care management, referral tracking, and most importantly, performance reporting to determine how our patient Wendy is really doing through the overall process. In addition to that, by use of a patient portal, the physician, Dr. Smith, can communicate with Wendy via secure access and allow Wendy to be in very much of a self-management mode in terms of how she cares for her own health. Because part of the goal of patient-centered medical home is an interaction between patient and physician that has really been unseen in much of the environment we've had so far. That leads to a more effective care management, and that is enhanced by effective e-communication between Wendy and her physician, Dr. Smith, that's handled between the patient portal and the EMR that you see on this slide. Then, Dr. Smith, by use of a health quality measures module, can determine performance reporting and figure out how Wendy is actually doing, determine data both by doctor and his overall practice, and produce standard reports because, as we all know, in the environment we're moving into, physicians not only are going to be measured by the care that they render an individual patient, but are also going to be measured by the care that they render within their overall practice. So the medical home model is a very interactive tool, one that is increasingly in demand today, and one that you're going to hear more and more as a segue to what we are hearing is going to be one of the big steps in patient protection and affordable care, which I'm sure both Mr. Merritt and Speaker Gingrich are going to talk about as part of the healthcare reform model. So we stand in partnership with Siemens to make sure that in the ambulatory setting we have the tools in place to be able to support the medical home model so that the physicians and the hospitals together can treat patients most effectively. So at this point, I'm going to turn things over to David Merritt from the Center for Health Transformation and let him talk a little bit about some information around the Patient Protection Act, and I'm sure that will be a great segue into Speaker Gingrich. David?
Thank you, Charlie, and thank you to Charlene, but also thank you to Siemens and NextGen, not only for being terrific partners at the center, but being industry leaders to really deploy the tools that are necessary both to improve quality and lower costs. As Charlie mentioned, and as Charlene mentioned as well, the crosswalk between the stimulus law and the funding for health information technology, along with the passage of health reform, is certainly evident. So what I wanted to do was to provide you an overview of what the new healthcare reform law is, provide a couple of those linkages by focusing on the quality initiatives, and then pass it over to Speaker Gingrich for some general observations on where we go from here. As Charlene mentioned, and as everyone knows, the Patient Protection and Affordable Health Care Act was signed March 23rd, 2010, after a very long and very tough debate. It was coupled with almost simultaneous passage of the Reconciliation Act that included some changes both to not only the health care bill, but also to federal student loan and some education reforms. That actually goes it paints a picture of what is actually in play right now as far as transforming the system, particularly when it comes to delivery. Several years ago, the Bush administration ushered in changes to the way that electronic transactions are made, as well as coding changes that will take place between 5010 and ICD-10. And then coupled with the stimulus bill and health reform, you certainly have a lot going on if you are in the industry. Now, when it relates to the health reform bill, what I wanted to do was start with just the general goals of the law. And I think that they settled upon expanding coverage. Now, if you look back to the campaign trail and look back to the beginning of the debate, it started on health reform, or started talking about health care reform, with broad goals of expanding coverage, lowering cost, and improving quality. If you look at the end product, though, it was very evident that they prioritized expanding coverage over the other two priorities, so there certainly is some work left to be done. Now, on the expanding coverage priority, though, there were some significant changes that are coming down the pike. The most expansive is the Medicaid expansion that will occur in the year 2014. The Congressional Budget Office estimates that between 30 and 35 million Americans who currently have no coverage will be ultimately covered by this law. 20 million of them will be covered through expanded Medicaid. The rest will be covered through the second bullet, which is insurance subsidies. They will find subsidies and tax credits to go out and purchase private insurance through an insurance exchange. And between those two, the CBO says that's where you come up with the roughly 30 million Americans who will ultimately find coverage. Those two also happen to be the most expensive parts of the bill. Medicaid expansion, I've seen numbers between $200 and $400 billion, and the subsidies, which will grow over time, are means tested and are available to families earning up to $88,000 a year. The third bullet around insurance reforms are actually the changes we'll see on the horizon sooner than many of the larger changes. In fact, some of the insurance rules are actually being developed and will be rolled out very quickly. Changes to how health plans can underwrite, changes to who can be covered under certain policies, changes to the limits between folks who smoke, or their health status, or the difference between underwriting based on age and health status. Many of those rules actually have already begun, the first of which will come online allowing young adults to stay on their parents' or their dependent care policy until age 26. There's also coming in the near term insurance exchanges where consumers will have the opportunity to go to new portals to actually compare plans and compare cost of plans and options for health insurance. Currently, or at the initial phase, it will be for individuals and for small groups to find coverage, but it will actually ultimately be available to large employers and large groups as well. But these will be at the state level for individuals and small businesses initially. This will be coupled with, in the year 2014, the first mandate or first requirement to purchase insurance. That will be coupled with some of the insurance changes, particularly to what's called guaranteed issue, which means health plans will be required to issue a policy to any individual, regardless of health status, at some point, and I believe that one is in 2012. But with an individual mandate, that will mean that individuals will supposedly be purchasing a policy prior to an illness. The individual mandate has an increasingly large penalty beginning in 2014, which is actually in 2014 it's only $95 or 1% of income, but gets progressively more severe where it could be up to 5% of income in the later years toward 2018. The last bullet on expanding coverage is for employers. This is one that you certainly should watch very, very closely. The House Energy and Commerce Committee was going to hold hearings last month around employer-sponsored insurance, particularly around news shortly after passage, where some large employers were actually writing off some future losses that they expect because of the bill. And Chairman Waxman, Henry Waxman of California, was going to call a hearing to investigate why these companies were doing so at this particular time. It turned out it was actually a law by the SEC to file such reports. But in the process of doing that, he unearthed some internal documents where large employers are contemplating the cost of providing health benefits and health coverage to employees and retirees versus what is, as you see here, paying an employer penalty, which would be upwards of 8% of payroll. Now, when some of these companies like Verizon, AT&T, Caterpillar, and other large corporations ran the numbers internally, many of them saw that paying the penalty was far cheaper than it was to provide the current level of coverage as they provide for employees and retirees. And so you will see over time every company really having this discussion internally, whether to provide the current level of coverage or to pay the penalty. If they opt to pay the penalty, that will generate about $130 billion in revenue, which will ultimately be used for individuals to purchase subsidies and to actually pay for certain parts of the program. But that's not something that will come online until 2014. But in the next couple of years, you will see lots of discussions over internally whether employers are going to continue to provide coverage or whether they will opt to pay the penalty. So that's a broad overview of the pillars on how the bill or how the law will actually expand insurance coverage. When you look at how the bill is actually paid for, it breaks down into two large buckets. The Congressional Budget Office, when presented with the Senate bill, estimated that it will cost approximately $1 trillion. And the two buckets to pay for that $1 trillion are taxes, raising new revenue, which totals about $500 billion, and then cuts to the Medicare program, which again total about $500 billion. Now, one thing to note is that the total cost is about $1 trillion, at least according to the Congressional Budget Office, but that was only the way that the legislation was actually written. What you'll see is over the next 10 years, many of the more expansive or more expensive provisions, such as Medicaid, such as the subsidies, don't actually come online until 2014 or beyond, whereas many of the taxes and many of the Medicare cuts actually take place relatively soon. So you actually have 10 years worth of revenue, but only about 6 years worth of costs. Some outside groups have actually estimated that the true cost, if you look at 10 years worth of costs and 10 years worth of revenue, would be closer to $2 trillion. But when you look at what was actually scored and estimated and presented to the CBO, it's about $1 trillion. It falls into those two buckets. On the taxes, there's a wide variety of taxes that will come online here fairly soon. The first are payroll taxes for the employee side, not the employer side, but the employee side of higher Medicare taxes beginning, I believe, in 2011 or 2012, where individuals or families making over $200,000 a year will see their Medicare payroll tax increase by about 1%. There will also be Medicare taxes on investment income. This does not include taxes for primary residences, but it does include investment incomes for other, stocks, annuities, and others. The employer penalties I mentioned previously. There's also a tax in the later years on Cadillac plans or high-value health plans. This is something that got a lot of attention during the debate. There are some plans that are valued at upwards of $20,000, $30,000, $40,000 because of how much they cover and how little the employee has to pay toward that coverage. and there is actually now going to be a tax on the value of the plan that's above $27,000 for a family and above about $11,000 for individuals. That doesn't come online until 2018, however. The quickest thing, or the things we'll see the soonest as far as the revenue raisers, are the fees that are assessed on various industries. These are primarily on three big ones: the device manufacturers, pharmaceutical makers, and health plans. The device manufacturers total about $20 billion over 10 years. Pharma is about $50 billion, and the health plan industry will see fees of about $60 billion over the next 10 years. These are simply costs that will be assessed to an industry that ultimately will be passed on to consumers. This is according to testimony by the Joint Committee on Taxation between the House and Senate. Just like any business that sees a higher cost, either in production or a new tax or a new fee, they will simply raise the price of that product for end consumers to make up for that higher cost to the manufacturer or to the business. And so we're talking about $130 billion worth of fees that will be passed on in higher premiums. Now, the bucket of Medicare cuts is fairly wide. They were equal opportunity cuts in that the cuts will hit a lot of different segments within Medicare providers, from home health to hospitals, quite certainly, to skilled nursing facilities and Medicare Advantage plans in particular. What's coming next? Just to walk you through a few of the immediate changes and then some of the longer-term changes. As I mentioned before, many of the immediate changes are going to be regulatory as far as health plans go and as far as underwriting go. As you can see here, rescissions, which are something that has gotten a lot of attention recently, where a member of a health plan pays his or her premium, but then ultimately starts filing claims and then gets their policy canceled. That practice will now be prohibited. Only in the cases of fraud or abuse will that be allowed. There are also limits to lifetime caps and to annual caps on spending. Typically, there are caps between $1 million and $5 million that are now going to be outlawed. And then, as I mentioned before, there are changes that will take place around dependent care and also underwriting for children with pre-existing conditions. The first change to Medicare will take place as well, I believe, beginning in 2011, later this year, where beneficiaries who actually hit the donut hole for prescription drugs will actually get a $250 rebate. Some of the other changes I mentioned, the young children, or as one person called them, adult children, can stay on their parents' health plans until they're 26. Tax credits for some small businesses are already available, though the qualifier or the qualifications and requirements for those tax credits are fairly tight. So I'm not sure how many small businesses will take advantage of it. There also is a high-risk pool that will be funded. There are high-risk pools that have been in existence for a long time, but the federal government will now fund new risk pools to the tune of about $5 billion up until the exchanges come online, up until some of the other changes come online. And these are to really try and focus on folks who cannot get coverage. They've had pre-existing conditions, they've had cancer, whatever the case may be, they can't find coverage. This is designed to have a bridge from now until many of the other changes come online. The problem, though, and CMS actually released a report recently that said that $5 billion will be exhausted by probably 2011. So we're talking about a year from now where that $5 billion will actually be spent, because there are many more people who are eligible and who are in need of a high-risk pool than there is available to be covered through the $5 billion. Now, the first tax is actually coming online 30 days from now. So if you're planning to do any indoor tanning this summer, you should definitely hit those tanners before July 1, because that's when a new 10% tax on indoor tanning services will come online. 2011 brings more changes to the regulatory environment around health insurance. The first cut to an industry is in 2011, where Medicare Advantage payments are frozen at current levels. and the first fee for an industry comes in 2011 as well on the pharmaceutical industry. One of the debates that's actually going on as we speak is around insurers and what's called medical loss ratio. There's a new requirement beginning January 1st, 2011, which will require that health plans spend 80 to 85% of all premium dollars on the delivery of care. So this will have to go toward medical services. So there will be a very important definition on what falls into medical services versus what falls into the smaller bucket, which will be marketing, overhead, advertising, profits, salaries, etc. And what this is trying to do is to squeeze the latter category in favor of spending on clinical services. But some things are in somewhat of a gray area, which might impact many folks who are on the call. How do you define pay-for-performance incentives? Where do you define disease management programs? Where do you define something like the stimulus bill, where the private payer has a similar approach where they pay incentive payments to doctors who adopt electronic health records or electronic prescribing? It's hard to know where these things would fall because many of them are not the actual delivery of care, though they certainly seek to improve it. But where that definition falls will be very, very important. In fact, that debate is underway right now with the National Association of Insurance Commissioners taking the lead. Beginning in 2012, again, we see more changes, mostly to the revenue side, mostly to the tax side, though as I'll show in a couple of slides, there are some quality measures that begin to come online in 2012. The most important one on this slide, well, two of them actually. One is a cap on contributions to flexible spending accounts. Currently, flex accounts, you're able to put in $5,000 in tax-deferred or pre-tax dollars. That is going to be cut in half and drop to $2,500. When you're spending and need to find $1 trillion to cover the cost of this program, they looked in a variety of places, and one of them was in flex accounts. And by cutting in half the amount of money you can put into a flex account, pre-tax dollars, it ends up raising about $10 to $12 billion. So for everyone who has a flex account, a dependent care account, beginning in 2012, you will only be able to contribute $2,500. Also in 2012, as what didn't receive a lot of attention but certainly should, and that's called the CLASS program or the CLASS Act. This is a new federal long-term care insurance policy that beginning in 2012, every individual who has a job will be automatically enrolled in this new program unless we actively opt out. If you choose to participate, you will have around $240 deducted every month in premiums to pay for this new long-term care program. That was an estimate from the Centers for Medicare and Medicaid Services. The CBO said it might be closer to $150, but you will need to contribute in premiums for 5 years until you vest and are able to file a claim for long-term care benefits, again, beginning 5 years later in 2017. The long-term outlook for this program is really something to look at because the CMS actuary has actually reported that this is the same exact approach that is used in the Social Security program, whereas it collects taxes, collects revenue, but pays out more in claims than it collects in revenue. So the way that the CMS actuary sees this program is following the Social Security model and becoming unsustainable very, very quickly. So something that may need to be re-examined down the road. Beginning in 2013, there are also more changes that come on for employers. That is when the first year for employer penalties will be seen. The excise tax on medical devices, the medical device industry is 2013, and there's a new fee associated with health plans to fund a comparative effectiveness trust fund, which brings us to the most important year, which is 2014. That's when you see the bulk of the provisions and the bulk of the law actually becoming law and becoming real for everyone. That's the first year, as I mentioned, of the individual mandate. Many of the more stringent requirements for health plans are in 2014, such as not excluding folks for, or excluding folks for having pre-existing conditions. This is the first year that federal subsidies will be available. This is the first year that Medicaid will be expanded from the current model, which is each state can set its own eligibility, to a federal floor of 133% of poverty. This is when the exchanges come online, and this is the first annual fee on health insurers, which totals $8 billion in the year 2014. From then on, you actually just see an increase in the penalties and an increase in the tax between 2015 and 2018. As you can see, the penalty for employers, for insurers increases to $11 billion. The penalties for not purchasing insurance if you're an individual increase as well. And then from 2017 to 2018, you'll see, again, more fees, more taxes coming online. Now, what I'd like to focus on, though, within that time frame, you will see some changes to the quality side. This is where the tie-in to the stimulus law and the incentives for electronic health records and other health information technologies really becomes vital and very, very important. First up, in January, there is a national quality improvement strategy to be released. Next year, we'll also see the CMS Innovation Center created, which for many of the providers on the line is often an oxymoron to say a CMS Innovation Center, but that's where many of the pilots, many of the demonstration projects will ultimately be housed that I'll discuss in just a moment. There is also a pretty clear priority within the medical community on primary care. The workforce issues in primary care and nurses, for that matter, have often been cited and often been reported. The law has a few things that go toward primary care, such as a bonus payment, which is available next year. There are also a number of pilots and demonstrations, particularly around value-based purchasing. As you can see, hospitals, home health, skilled nursing facilities, and ambulatory surgical centers all have what starts out as value-based purchasing programs, but will actually migrate to required participation down the line. 2012 is also important because that's the first year that Medicare and Medicaid will have demonstrations around accountable care organizations. These will be built upon or based upon a current CMS demonstration around group practice. This is where shared savings and coordinated care will be the hallmarks, and in order to qualify as an ACO, there will be a number of requirements that will be laid out by CMS over the next 18 months. But you can better believe that health information technology will be imperative to participate in these, but also will be imperative to realize some of the cost savings as well as some of the coordinated care. Next, you'll also see in 2012 and beyond some of the payment or reimbursement changes. Hospitals will see two important changes down the line. One is to payment cuts for preventable hospital readmissions. What readmissions those are, how they're going to determine what they are, what quality measures they're going to use will, again, be determined over the next 18 months. But beginning in 2012, for certain readmissions, hospitals will not be reimbursed. There's also a step toward more transparency when it comes to Medicare claims data. There's been a lot of controversy around making Medicare claims data available to the public for research purposes. If you've seen any of the Dartmouth Health Atlas research, that's all based on Medicare quality and Medicare claims data. They do open the door for more organizations and more researchers to access that data beginning in 2012, but again, there will be some restrictions around the use of it. There's also a bundled payment pilot beginning in 2013, and then you'll also see a lot of changes around quality reporting. At one point, PQRI, which is at this point a voluntary reporting program which provides incentives for reporting that I think about 1 in 5 physicians has actually participated in, will actually become mandatory in the year 2015. But again, many of these changes will be defined by CMS and HHS down the road. So the importance between the stimulus money and the incentives for health information technology really become very, very clear when you look at the changes that the law brings to the quality side. When you think about decreased payments from Medicare, when you think about more Medicaid patients, when you think about more quality reporting, it's going to be impossible to do so with a paper office. And they provide incentives, very generous incentives, in the stimulus bill to actually migrate and adopt and meaningfully use health information technology. So the reasons for adopting now are only going to get more important and certainly clearer as the law becomes as the law is implemented over the next several years. So that gives you a high-level overview of most of the big pieces of the law, from the coverage side to the quality side. And with that, I'd like to turn it over to Speaker Gingrich for his observations.
Well, thank you, David. As all of you can see, David is hardly lacking in material, and I think now has a lifetime employment just going around explaining stage by stage, year after year of implementation. I just want to offer a couple of very high-altitude views, really starting with Center for Health Transformation meeting we had in Richmond with Governor McDonnell a couple weeks ago, and then conversations I've had recently with Governor Rick Perry in Texas and with some key health leaders in California. I think my first point would be the sheer complexity of this, which we've tried to represent at healthtransformation.net, where we have a chart that you can put up on your wall that shows the 159 new offices and agencies, 3 feet by 6 foot chart. Just start with that, and then you go through the 53 pages of deadlines, which Governor McDonnell pointed out was actually very misleading because it did not include the 50 states, which have their own deadlines built in. And so you start adding those in, and you begin to see how complicated this is. My first observation is that the sheer exhaustion of trying to understand all the parallel moving parts is going to be a major problem in any serious health dialogue over the next year or two, because people are just going to be drowning in the scale of different activities occurring simultaneously, and in learning whole new languages, whole new regulations, whole new proposals. So I think that nobody should think we're at the end of the process. We're sort of at the beginning of the process, and it has a long way to run. My second observation is that everybody should focus on becoming the lowest cost provider possible, because you're going to be compelled to take cost out of the system. To the degree you don't take cost out of the system, in the long run the politicians are going to ration care and ration price, as they already do with Medicaid. And one of the grave dangers, as was put to me by somebody who's runs a very significant health operation, said, basically we're all going to be at Medicare or worse by the time this is done, because of the incentives to the business community to get out of the employer-based system, which has historically cross-subsidized the underfunded government programs. So if you imagine a world 5 or 6 years from now in which everybody is now Medicare or less in payments, you have some idea of the challenge providers are going to face. The third point I'd make is that there will be a rapidly emerging standard of care which involves electronic health records, involves a focus on quality, and involves a series of reporting patterns totally different than anything we've ever seen before. I think it is basically unavoidable, and I think that those people who understand it, adapt to it, and learn how to use it faster will have a substantial net advantage, because the very nature of the health system that's going to emerge is going to involve a great deal more transparency and a great deal more reporting than we've ever seen before. And I think in that sense, thinking through the medical home model, thinking through the electronic health record application, making sure we get to interoperability so that people have access to the same health data, whether they're in the hospital or they're at their traditional doctor, or they happen to be on the road and have a health emergency while they're traveling. All of these things are going to come together at a very rapid rate. But my prediction is going to be, in the short run, people are going to be relatively unhappy with this bill, The more they learn about it, the more unhappy they're going to be. But they're going to be really absorbed in phase one in trying to implement it. And one of the interesting questions is going to be, whatever happens in the election this fall, what are the kind of hearings Congress holds starting about March of next year? Because it'll be clear by then that the bill in its current form can't possibly operate, and that there will have to be substantial modifications, whether you're a liberal or a conservative. Just the sheer complexity of the bill and the second and third order effects of the bill are going to lead to a demand for hearings and a demand for revisions probably as early as next spring. And that's kind of my initial overview. But as you could see, I mean, what David laid out for you is just an enormously complex, massive effort to rethink and reform 20% of the economy. And it's, whether you like it or dislike it, it's one of the boldest efforts in American domestic politics, certainly in our lifetime. And how it all ends out, I don't think anybody knows at this stage. But prepare to be fairly absorbed just understanding the different changes and the different efforts that are underway by the end of this summer. So I think, Charlene, we're open for questions, comments.
Okay, I'm back online. Yes, thank you very much. I hope the audience kind of got the broad view. I think we provided a lot of content, so we're now open for questions. Nikki, do you have some coming in?
Yes, there are a number of questions. I'll start. Okay, this first one is probably for you, David, or anyone else, any of the other speakers who could comment. Could you describe a typical Cadillac plan, and who is paying the tax on that plan? Is it the individual, the health plan, or the employer?
Very good question. A typical Cadillac plan or high-value health plan hits a number of different constituencies at this point. Typically, though, unions and organized labor have been the ones that enjoy what are now called Cadillac plans, which are health insurance policies that cover virtually anything and everything and have very little out-of-pocket expenses for the member. So, for instance, in lieu of wages and collective bargaining, many organized labor movements will negotiate for high-value health plans or Cadillac plans, which is just a form of a benefit concession. So you'll see lots of unions that have very, very high value plans, but don't pay into them. I grew up in Michigan, so I know the auto industry very well. The United Auto Workers has one of these plans. But you've also seen on the other end of the spectrum a lot of executives that have these sorts of plans. In fact, the most notorious, I think that's the appropriate word, in the debate was a Goldman Sachs executive who had a Cadillac plan that was valued at $43,000 just for his family. And again, that covered basically anything and everything with very little out-of-pocket expense for himself. So the way the law is written, it's trying to reduce the demand for these kinds of all-inclusive health insurance plans to try and reduce costs. Because if you're allowed to consume more and you can cover more and everything is paid for, ultimately you will consume more. So by placing a 40% tax on the value of the plan, this is one way to try and put a cap on utilization. Now, who ultimately pays it? At the end of the day, it will be the consumer, because as the law is written, if a employer or a health plan gives a policy that's worth more than $27,000 for a family or around $11,000 for an individual, there will be a 40% tax placed on the plan, so that will ultimately fall to the consumer. So that's another reason why folks will, I think, turn away from these plans when that tax comes online. But again, that doesn't happen until 2018.
Okay, thank you. Okay, this next question is about expanding coverage. David, you talked about a number of the expansions of coverage, and this is really about the pay-fors. Recently, it looks as if, I'm paraphrasing a little, in one area, a local payer came out and said that just for the one provision where children under the age of 26 are covered is going to cause an increase for all participants in that plan of 1.5%. So everybody who has that plan will pay 1.5% to cover the children under 26. So that's just one of them. How do you see that playing out as the additional coverage comes online and the pay-fors and the impacts of that?
Well, generally speaking, we can't have it both ways. I mean, that's what I think a lot of folks were hoping for, is that you can cover more people but pay less. And that's just simply not going to happen. I mean, it's against the law of economics and everything else. You take the example that you mentioned about dependent care. We've actually talked with one of the larger insurers in the country who said that change alone will not be 1.5%, but in the neighborhood of 2 to 3%. Because, again, you're simply covering more people without paying more. It just can't happen. So you'll see a lot of those things down the line, particularly when it comes to these insurance fees and the industry fees. The pharmaceutical companies, the device companies, they aren't going to absorb those costs and pay for them themselves, which is the way that I think several or some politicians wanted it to happen. They will ultimately pass those on to consumers. And the best quote I saw to explain it was from the chief of staff to the Joint Committee on Taxation, which said what he said was the prices for insurance will rise exactly as the cost, or how did he put it? Prices will increase in the exact amount that the industry is assessed a fee or a fine. So there is a relationship between how many benefit changes you can load on, how many more people you can cover, and ultimately it is going to cost more to cover more people. I mean, that's just, as I said, a simple law of economics.
No, this is Newt. Let me just suggest also, you can understand this bill a lot better if you start with the premise that the people who wrote it actually do not intend for the current private sector system to be in a position to survive. I mean, if you designed a bill that said, on every front, we're going to make it more expensive to offer private insurance, we're going to raise the cost of private insurance, we're going to lower the profit margins, we're going to maximize the regulatory burden, we're then going to make sure that you have to offer a series of very unacceptable subsidies, none of which you'll be able to absorb, so that year by year, private insurance will become more expensive, less offered, less available. You have sort of, the bill then makes sense. And if you combine that with the provision that starting in 2014, there will be an absolute incentive for the private sector to basically dump everybody out of their insurance plan and put them into an exchange where they will buy the highest possible cost insurance, which is the individual model, so that you will, by 2015, have created a huge national demand for a government-run health insurance program, because everybody will recognize that the private sector insurance has failed. Then the bill then makes sense. And then if you just analyze the bill with that as its long-term goal, it is a reasonably clever device to minimize the survivability of the current health insurance system.
Okay. This is sort of a bit of a follow-on question to the point you raised, Speaker Gingrich, about the efficiency required in encouraging all providers to become as efficient as possible. This question is, do you anticipate U.S. hospitals facing big financial troubles in 2014 and beyond? Will there be less hospitals functioning moving forward?
Not necessarily. Remember that one of the options that you get with the British and Canadian system is hospitals function. They just drop all their expensive procedures. So they figure out which things are the least expensive, highest profit models, and they do those, and they drop everything else which is risky or rare or involves team efforts that are expensive. And, I mean, you can have a very cheap health system with many surviving hospitals. They're just not very good hospitals. And I think that you've got to look at the grinding down effect of what's going to happen with, and this is true of doctors, by the way. everybody seems shocked at the idea that we have fewer and fewer people who want to go into medicine, and yet we underpay them, we overregulate them, they're surrounded by red tape, and they face a constant threat of litigation. And so you have to say to yourself, what do you think is going to happen? And I think the same thing is going to be a problem for hospitals, because the hospitals have survived for about 40 years by deliberately overcharging the private sector in order to cross-subsidize the government, which has refused to pay the real price of its demands. If you now have the private sector beginning to refuse to be the source of cross-subsidization, you're going to have a dramatic increase in cost.
One thing I'd add to that, specific to the question about hospitals, is that CMS released a report, I believe earlier this year, I can't recall if it was before or after passage, but I think it was before, that said the proposed cuts to Medicare for hospitals in particular would jeopardize 1 in 4 hospitals surviving. And when you think about more than 5,000 hospitals out there, CMS estimates that perhaps upwards of 1,000 of them will be hemorrhaging under Medicare cuts. So this is very, very serious. And beginning in 2014, when there will most likely be fewer private payer insurers and fewer people covered by private payers, hospitals in particular could be facing a lot of challenges.
Okay. Next question is for Charlie Jarvis. Can you please clarify the difference between the concept of medical home and accountable care organization?
Sure, happy to. The medical home is much more of a singular relationship. It's the relationship between an individual patient and his or her individual group of healthcare providers, whether it be doctors, the hospital, lab, radiology, et cetera. The accountable care organization is a much broader concept, which is more of a population management approach, where you say this population of 1 million or 2 million or 3 million people is going to be served by this broad group of healthcare entities, including multiple doctors, multiple hospitals, multiple organizations. So in a high level, think of the medical home as the individual doctor-patient relationship and the accountable care organization as healthcare population management.
Okay, thank you. This next one is for David. David, could you explain more about the class provision you discussed in the long-term care insurance?
Sure. This is actually something that Senator Ted Kennedy pushed for a long time. It's a new federal product for long-term care insurance. This is for anyone and everyone, not just for Medicare, but this is for anyone and everyone to purchase long-term care insurance through the federal government. Again, the premiums collected, you'll need to pay in for 5 years before you can file claims for long-term care for a long-term care benefit, which is basically designed for folks with who you want to stay out of who have long-term care needs, non-medical needs for assistance. And the way that it's designed currently is that everyone will pay the same except for a small portion of low-income Americans whose premium would be $5 a month. That's in the law, $5 a month. For all others, it will be between $150 and $240 per month in premiums for this new long-term care insurance product. And as I mentioned, Americans will be automatically enrolled unless we actively opt out of the program. And again, that comes online January 1st of 2012. And so your HR department will certainly be contacting you whether you want to participate. But many of the details, like a lot of these changes, are yet to be defined and will be outlined in the regulatory process in the coming months and years.
Thank you. The next question is about a number of the delivery reforms in the legislation, the value-based purchasing, some of the equality initiatives you discussed. The question is, could the speakers comment on the benefits of the proposed payment initiatives on healthcare quality?
I'd be happy to take the first stab at it. I think that of the bill and the provisions that have the most potential to truly transform the delivery side of care would be in what's called Title III. That's where a lot of these demonstrations, a lot of these changes to reimbursement will be found. And the reason why I think those are the most important pieces of the bill is because regardless of if you have insurance or if you don't, we all want to have improved quality of care. And if you can actually improve the quality of care, we think you can bring down the cost of care for everybody, regardless of if you have insurance. So the need for payment reform, the need for paying by value, and when you see these programs about value-based purchasing, what that means is that reimbursement will be tied to performance at some point. Now, in some of these programs, it's a very small percentage of reimbursement that will be tied to performance. I believe in the first year it's only 2% of reimbursement will be tied to performance. And again, how you tie it to performance, what quality measures are taken into account are yet to be defined. But I think the movement toward value-based purchasing, the movement toward payment reform and reimbursement reform is really one of the seeds that could grow into something very transformational and very, very positive. I mean, it's something that Speaker Gingrich has worked with Senator Daschle on. It's something that certainly Charlie Jarvis and other members of CHT have been involved with. It's a very difficult issue, but at the same time, it's one that I think can provide the biggest bang for the buck.
Let me reinforce what David just said. We have a special project under Julie Eckstein, who runs our office in Missouri for the center. And the whole purpose of the project is to try to intellectually understand what are the requirements to shift to a values-based payment system that allows you to really deal with things like chronic conditions in a way that maximizes the right behaviors and that aligns values with financial incentives. And I think this particular area is probably the most important zone in which to fundamentally rethink the health system if we're going to break out of the way it has been operating up to now.
This is Charlie Jarvis. I agree with Speaker Gingrich's comments there, but having been a member of that task force, the paradigm shift is phenomenal. And I think it's extremely important that if we're going to bring about those kinds of changes, which I totally support, we have got to be willing to think the unthinkable and make some major change that is not necessarily consistent with where our model is now. So I think we have a unique opportunity to do that, and I encourage us to move in that direction, but it is going to mean major, major paradigm shifts for that to happen.
Okay. I again want to thank our speakers today. To that end, one of the things that we participated in with the center, and David, maybe you want to tell a little bit about it, NextGen and Siemens both contributed chapters to the new version of the book Paper Kills 2.0. You saw that on your registration screen, and as a follow-up to the webcast, you'll get another copy of it. But in there was a significant number of industry contributors who are really putting forth a vision similar to what we just talked about, and it's specifically relating to the role of IT enabling the type of transformation we're talking about. So again, I encourage you to take a look at that book. David, I don't know if you've made it in an e-book yet or if you want to add any more commentary.